Hello, everyone. I am Dr. Georges Benjamin, and I'm chair of the Committee for the Analysis to Enhance the Effectiveness of the Federal Quarantine Station Network based on lessons learned from the COVID-19 pandemic. I would like to welcome everyone to this open session of the committee's second meeting. And we'll note this is a on the open, on the record information gathering session, which we are recording. The committee is in the process of assembling materials that will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here thinking otherwise today. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. Now, this is the second of approximately 4 to 5 planned full committee meetings. Some of these meetings may include public sessions where we have the opportunity to hear from experts in the field. The committee will deliberate thoroughly before writing its draft report. And moreover, once a draft is written, it must go through a rigorous review by experts who are anonymous to the committee. And the committee then must respond to this review with appropriate revisions that adequately satisfy the Academy's report review committee and the chair of the National Research Council before it is considered an NRC report. The expected report release is around May of 2022. Further information on the study, including future meetings, can be found on the project website. Now, this open session today provides an opportunity for the sponsor of this study, who's already addressed this committee, and in many ways, they describe the context and reasoning that went into the committee's work. Now, today we have some additional speakers, and it's my pleasure to introduce the speakers for this session: Gary Rascott, who's the acting assistant secretary on counting weapons of mass destruction at the Department of Homeland Security, who will talk to us about what DHS interacts and partners with CDC's border quarantine stations. Gary, thank you very much for being here this morning.
Hey, good morning, and no, thank you for that introduction. And it's always a little strange with the title. That's part of my day job, but part of my other job is that I supervise the department's chief medical officer as well as the medical operations of the department. So then it is in that role that we work very closely with CDC and DGMQ in particular. Can I get to the next slide, please? So this is really where, just sort of to frame the DHS sort of partnering with CDC and DGMQ, I think you can see that, we've all got this sort of public health, protect the public mission. Ours is a security base, CDC's is a public health base. But in the middle, you can see that, we are always balancing sort of the public health aspects with the enabling legitimate travel, with safeguarding the borders, and then of course, providing services to immigrants, refugees, and travelers. So it all comes together sort of in the middle, and in many places, it all comes together at the port of entry, which is where we work very closely with our CDC DGMQ colleagues. And CBP, while our primary agent in that, Coast Guard has similar authorities where they are actually by law authorized to assist both CBP and the Coast Guard to assist CDC in any quarantine operations. And from the beginning of the pandemic, we have been working very closely with CDC to sort of operationalize their public health requirements and using our screening, vetting expertise, our ability to rapidly contract for those type of things to really, at CDC's request, fill in some of the gaps as we continue to learn more and more about COVID and what screening would work, what wouldn't work. And it's been a real pleasure actually to work closely with CDC. And I think working through things like, and I'll talk about this in a minute, the enhanced entry screening at the airports, the contact tracing for international air arrivals, then ultimately the new regime of international air arrival procedures that were announced earlier but took effect on November 8th. I think we've strengthened actually the public health operational aspect of the country by really bringing DHS and CDC closer together. We each have a better understanding of our individual capabilities and authorities. And I think where the real force multiplier comes is that we now have a much better understanding of how to integrate those in a way that helps both CDC and DHS accomplish their mission. So can we go to the next slide, please? So my personal involvement in sort of the COVID response started in probably before many folks were even understanding what it was. And I can recall this very clearly. Although I don't recall the exact date, it was an early Sunday evening in January 2020, and I got a call from Dr. Marty Citron from DGMQ saying that, hey, we probably need to start some screening from folks from Wuhan, China. And I wasn't even sure where Wuhan, China was at the time. And of course, we all know where it is now. And that's how we got started. And we had done in the past some work with CDC on the Ebola screening. And following 2016, we got together with CDC and looked to see how we might do that better and establish some existing capability in 5 key cities and started training folks there using state and locals or public health institutions or some private contractors, whichever fit the bill the best. And then we were just sort of starting to finalize the lessons learned from the previous couple of years of Ebola screening when the COVID started up, and we were able to leverage that learning and that integration with CDC to really rapidly respond. And I think it's important, and I know most of the folks on this screen know this, but that, we were learning a lot almost on a daily basis. And while some of the screening that we may have done for CDC ultimately may have not had the medical efficacy that we had hoped for in the beginning, when we did it, it was the consensus of the community. It was the right thing to do. And we were able to stand up that capability at 11 airports as we did the first travel restrictions from China, literally over Super Bowl weekend. We expanded that to 13 airports later as we expanded the travel restrictions to include the EU, UK, and then ultimately Brazil. And I think we ended with 15 airports where we were doing the screening. And that was a very collaborative effort between the CDC, CBP, and then our DHS screeners. Our screeners were contracted, and ultimately CDC reimbursed us for the work. And I think it's just a good example of how departments can leverage their individual capabilities to achieve the desired national outcome. Also on the contact tracing, we were able to work very closely with CDC to use some of the existing CBP data systems with the airlines. And really, because of our habitual relationships across DHS, whether it's TSA, CBP, or the Coast Guard, with both the aviation and maritime industries, we were able to facilitate some discussions for CDC with the industry and serve as sort of a middleman translator of what CDC was trying to accomplish to an industry that maybe didn't understand it, and then going back to CDC to maybe giving a little more color and context to some of the industry questions because of just some of the physical limitations of perhaps aircraft or ships that may not be readily evident as you begin to work some of these issues. I think one of the most powerful things to come out of the partnership also was just a much stronger relationship with both the aviation and the maritime industry in understanding what the shared public health goals were and how best to attain them. Can we move to the next slide, please? Some of the interagency coordination that we worked very closely with CDC on was an FAA project called the Runway to Recovery, in which FAA and DOT sort of led with CDC's help and collaboration, working the industry to measures that could be taken to mitigate the impact of COVID on the travel on travelers and the travel system writ large. And CDC was very helpful in helping the interagency to understand that the travel part is a door-to-door issue when it comes to public health. Because I will offer to you at the beginning, I think a lot of us were focused on the airplane itself, or maybe the cruise ship itself, but CDC helped us very quickly and very comprehensively understand that it's really the door-to-door experience that we have to look at and protect the public's health with. And I think we got much better in that as the days went on and we learned more. And the runway to recovery was just that, sort of the whole travel experience via air. And we'll talk about the conditional sale order in just a minute. You can see some of the international travel orders that were worked. I think the first one to come out was the global testing order, which we worked very closely with the industry, both CDC, DOT, and our DHS, TSA, and CBP entities. And on that one, we understood that was, given that it was going to be the first order of its kind, we did it at a little smaller scale. If I'm recalling correctly, we did it for 2 weeks in the UK, and then we went worldwide with it to allow the airlines and others to adjust. When we looked at doing the vaccine order, which just went into effect on the 8th of November, we were looking at doing an actually similar model to that. But we decided that in consultation with the airlines, that having gotten a year's worth of experience with the global testing order, and because we were having near daily meetings with the industry, that they were willing to go with worldwide implementation right off the bat. And, so far so good. We've had a couple bumps that CDC has rapidly helped us iron out with some clarifications to their orders. I think it's, important to know if you're not 100% familiar with sort of airline or maritime operations, that travelers will do what travelers do, and we can anticipate. But until the orders actually go into effect, there's always going to be a few questions that the industry will need clarified. And CDC has been extremely responsive to the forums that we've set up to responding to those answers. On the conditional sale order, DHS has worked closely with CDC from the no sale orders right on through to the current structure. And I think we were able to establish a forum once they had published the conditional sale order, and we were able to meet quite regularly. I think it was about every 2 weeks, maybe it was every week for a while, starting in the March-April timeframe, with really the CEOs from the cruise lines, sponsored by both by CDC and DHS at a very senior level, and really solicit their input. And you have to be careful here, because we are the regulators, but I think you always are okay when you're soliciting input. We made it very clear to everyone involved that it was not a negotiation of public health. But I think you really need to understand from the folks that do this every day for a living how they would implement, or what the constraints are to implementing certain aspects of regulations that you want to put in place. And I think it's just a more productive environment when the folks that you're wanting to implement these things get a better understanding of the underlying public health or security reasons why you're doing this. And so we were able to have some very productive conversations, which led to the beginning of the cruise season again this summer. And I think if you look across the cruise industry, you'll find an industry that is that is committed to public health and is living with COVID now, as opposed to sort of trying to get away from it. They've understood it through the help with CDC, and they have worked very closely with CDC to make the ships as safe as possible. So I think another really good example of where a relationship grew through the pandemic, and the collaboration has worked. And we are really seeing from all the industries, what I like to term enthusiastic engagement, as opposed to reluctant compliance. They're wanting to share in the public health goals, and they're doing all they can to attain them. Can we move to the next slide, please? Finally, where do we go from here? one of the issues here as we work closely with CDC and DGMQ and it's just the way the federal government works, and there's something, called the Economy Act, is that we need to work out the funding for who's, we can always help other agencies with their missions, but we need to be reimbursed depending on the very specifics of our authorities versus their authorities. And so where we're trying to head here is to look towards a longer term solution. We've done a couple of memorandums of agreement, or MOAs or MOUs, memorandum of understandings, to get the funding straight within the federal government for reimbursement. But we're working closely with CDC now to sort of get a longer term document that we could use at a moment's notice, so that we don't have to go through some of the legal wrangling back and forth with our finance people to make sure that it works out. So that's one of the things we're trying to do. I think one of the things the committee should consider, I think you have to have a ready capability to do some of this screening, be it at airports or otherwise. I'm not sure who the right person is, and I'm not certain that, I think the public health officials, CDC, should set the requirements. I would suggest that our experience shows that they don't necessarily have to operationalize that, although they certainly can. But it is an episodic capability that you may want to look towards a contracting rather than maintaining a full federal capability. I think these are good points to discuss, but I think that, what we've shown over the last 2 years is a unique ability to leverage both the capabilities and the capacities of CDC and the DHS components to really attain the desired national health or public health national outcomes. And I think it's worked. There were certainly some bumps in the road as we learned different things, both from our side and the CDC side, but certainly always a willingness to engage, take the feedback, and take it to the next level. So that's the extent of my presentation. I'm very happy to answer any questions that you might have.
Gary, thank you. Let me, we'll open this up, of course, to Q&A. And if there are public attendees that are out there, I just want to let everyone know that, of course, the committee needs to get their questions answered first. But if there are any public members out there who are interested in asking questions, they can email the project email address listed on the project website. If you wanted to make a comment. And for the committee members, if you use the reaction buttons to raise your hand or type your questions into the chat box, or the wavy hands sign that we always talk about, if you have any questions. If I could start, Gary, obviously you folks were doing screening. What was it? Can you give me a sense? Was there a real difference between what you folks did under contract versus what CDC and their staff did? I mean, functionally, what was the difference?
So it's more about capacity than capability there. DGMQ was always on scene because, we'd set up a screening, and our contracted folks would do sort of the preliminary screening. And early on it was temperature checks, symptoms, and some questions. And if anybody was positive, they would be referred to the quarantine folks that were at the airport. But it was really just a way to maximize the limited quarantine folks. I mean, because if we had them screening all those folks, they would have been exhausted. And we were able to bring the screeners in to really sort of, I don't know, for lack of a better term, filter through the travelers. And if you recall, when we put the travel restrictions in place, U.S. citizens and U.S. persons were allowed to still return. So we're primarily screening U.S. persons that were coming back from the countries that we had placed the travel restrictions on. And so there was a lot of people in the beginning. And so it was really a way to sort of amplify the capability of DGMQ and reserve their specific expertise for when required.
And how did you triage people to be screened? Would you screen everybody or people that?
We did. we screened everybody in the beginning. We screened everybody that was returning.
Got
And
it.
we had contractors in place at, I guess it was 11 airports, then 13, and it was a 7x24 operation.
Thank you. So Michelle, Stephen, Clive, and Jason.
Sorry, I wanted to unmute. Thank you for that presentation. Couple of questions. One, is it clear who operationalizes screening? Were the chains of command quite clear? Is there any way the committee can clear that better? And the second question is, one of the aspects that we clearly failed at was contact tracing. Who is responsible for that, and how did that get taken care of?
So I think it can always be clear, right? Anytime you have an operation, the first thing you look at is in the after action report, it'll talk about communications, and they'll talk about sort of chain of command and all that. But I think the committee, if there was a recommendation, I think that it would be that we kind of go in the direction we're going, which is we formalize through a memorandum of understanding or a memorandum of agreement, or whatever the right legal vehicle is, the way DHS provides these services to CDC. And if the committee in fact likes that model, I mean, maybe you guys want to go with the idea that CDC should have all this in-house, which as long, and that's been a recommendation prior, but it's always a recommendation that never quite got fulfilled. And I don't think I'm talking out of school here, because I think that came out of 2016 as well. But you have to build the capability, right? Because you're going to need it. And unfortunately, in 2020, when we needed it, it just wasn't quite there. So we reverted back to what we've done before, and we used the DHS capability. I think maybe that's a better way to go, but I think we need to formalize that and have that those processes, the funding and all that sort of set up in advance. So I'm not scrambling to try and convince people that we really should do this in the national interest. And on the contact tracing, granted, it's 18 years, right, since it bubbled up, but it's out there now. And a lot of different issues there, a little bit of industry hesitancy over maybe a decade and a half because of the expense, then some internal coordination within the government. I would just offer that it was a really collaborative effort at the end to bring together both the industry and the government to finally get that done. And it's out there now, and I think we're better for
it. Okay, I'm not sure it's out. I'm not sure it's completely functional yet, but we can.
Well, they have 30 days. I mean, we are. I mean, certain of our overseas airlines are not able to actually take any of the preparatory steps until there's an actual government order asking them to collect other items from their passengers. The privacy rules across the globe are varied, and unfortunately or unfortunately, we have to sort of comply with them all as we do this. So that's part of the rub. But I would suggest, and I'll yield to CDC on this, but I think we're on a path where we should see, very good compliance within the 30-day period.
Stephen.
Yeah, I was actually going to ask something very similar to what Michelle just asked, which is I worked at CDC for a long time, and this issue of flight manifests was, horrible. And, especially with the reticence of the airlines to provide that type of data. You're making it sound like that largely has now been fixed. I guess the question is, how quickly can you actually get a flight manifest and start initiate the tracing process?
I guess I would.
And then I do have a second quick question, which is that you indicated that you contracted out for the screeners at the airports. Can you give us some sense as to who they were that were actually doing this?
Sure. So on the contact tracing, I would maybe take a look at the global contact tracing order that came out on, I forget what day it came out, but it was like before November 8th, because it clearly indicates what the airline's responsibilities are. And basically, they'll collect 5 data elements from each passenger and have it ready upon CDC request to be transmitted to CDC. Some of the folks are transmitting it via their existing transmissions to CBP in a system called APIS. So it's already in the CDC library, and we have a liaison, a CDC liaison at the National Targeting Center at CBP, so they can pull it there. So I don't know, and Clive or Marty can tell you if they've actually needed to use that data since October 8th. So I don't know how quickly, but the airlines are. There was a turn, I have to tell you, probably in the last year, and this is what I was kind of alluding to in the beginning. We started working more closely with the airlines, we as an interagency, and I think over the year we changed that relationship, and they were actually very aggressively supporting the contact tracing, and the U.S. airlines in particular. A lot of them were doing it voluntarily as of last summer. And so I think, we're still in the implementation period, but I think you'll be very pleased probably by the end of the year as to where we are. I'll certainly yield the CDC on that. On the screeners, primarily they are off-duty first responders, paramedics and the like, not doctors, but medical professionals. AMR was one of the big companies that we used. And that's based on some of the work that we had done in the Ebola screening. Does that answer your questions?
Thank you. Clive.
I can't hear you, Clive.
Sorry.
Muted.
Thanks. Yeah, to put what Gary said into some context, and I absolutely agree with Gary that the partnership has been amazing. We say of CWMD, about CBP especially, they are our eyes and ears, because we are at a few airports, and CBP especially is at every airport. But in the context of some public health response, you can put it into 3 kind of sections. What CBP has traditionally done for us is what we call primary screening, where they kind of identify and target persons who need to be targeted for public health response. So in this case, it was based on what we call the 212F countries. So it initially wasn't the entire world, but the 20 or so countries that were targeted, China, European Union, etc. CBP identified those persons for us, for the airlines to make sure the right steps were taken. And then those who arrived in the US, this is where CWMD came in. CBP would then charge those persons to be evaluated in what we then called secondary screening by CWMD, the contractors, mostly EMS, etc. CDC's main role has always been the tertiary response role. So CBP or CDC or CWMD or airlines or other airport partners will identify persons who need further public health evaluation. So CWMD essentially did the secondary screening piece, then persons who needed more intense public follow-up were then passed on to CDC to evaluate further. In terms of the contact tracing, it's a little early to say. I will say, we're evaluating the data now. In terms of the airlines, what Gary said is 100% correct. We have been getting much better responses from the airlines leading up to now. So whereas it to take sometimes a week to get airline data, for some good airlines, we're getting it in 24 hours. So just the relationship alone has led to an improvement in that reporting process. But we will need a few more weeks to evaluate the change to be able to report out. Over.
Thank you. Jason.
Thank you for the presentations. I have a question about speed. So when we know that the virus is coming from Wuhan, and it takes 14 hours to get to San Francisco where I practice. And so to what extent can we ramp up the speed in which, we screen, and what are we screening for? So how do we quickly establish sort of a list of criteria on which to screen for? As we watch what's happening in Wuhan, where the hospitals are overcrowded, people are dying in the streets at the time, the WHO, I just looked in the WHO website on February 29th, it still says WHO continues to advise against the application of travel or trade restrictions to countries experiencing COVID-19 outbreaks. This is February 29th. And so even the WHO was very late in ordering these travel restrictions. So for the next time, the next pandemic, how do we improve the speed of the response? That's my question.
Yeah, so I'm going to yield to CDC on that one because I'm not a public health expert. I'm an operator. And really, we just worked in partnership with them. When they were ready to do it, we were able to help them do it. So I'm going to have to pass on that one.
Jason, if you'd like, let me just give a framing. So you're right, the WHO approach has always been, the risks of border measures may outstrip the benefits, especially if it chills surveillance and reporting of spread. On the other hand, national governments, are making statements in particular national interest, and screening started early in surrounding Asian countries. You'll recall this outbreak broke during Chinese New Year, and so there was a lot of movement and there was a lot of concern. Some of the very first exported cases were picked up by temperature screening. As Gary indicated, in the very first week of January, it wasn't clear that we had all the data on what the best protocol would be, but it was clear that we needed to stand up a surveillance tool. Even if it were to be inefficient, we needed to call international attention to the fact that exportation was going to be a first and foremost concern. We would have to refine that tool many times for it to be useful for the purpose, but there was no doubt that it was necessary to have eyes and ears wide open, even before there were tests and other kinds of things. Screening is, we've managed this for Ebola, and there are two things that have to go into that. One is, can you find the contagious and the sick cases in transit that have left and are arriving, and recognize them and properly mitigate and contain them? But there's another very important part, which is even harder, which is how can you find the cases, or how do you risk stratify those that are coming that are at risk of becoming cases over an incubation period? And so forward following for an incubation period is even a bigger challenge, i.e. those you let through is even a bigger challenge to screening algorithms. Neither of those, Gary's absolutely right, we've made progress. For me, it's since SARS in 2003 that we've really had a stall on this, despite multiple examples of why it's important. And what we need is timely, very fast, timely stand up and very fast turn real-time data. We need it to be accurate. We need it to be complete and comprehensive, and it needs to be actionable. And none of those things have been in place. Those are the kind of requirement phase. We actually need it to be legal so that we can get it, meet those, and we have to have the capacity. So I think we know the outlines of what this is, what we should do, and then it's what can we do and what may we do. I believe what Gary's talking about is solving some of the capacity scale issues on just the transport side, the federal side, and the may issues. We're finally getting authorities that people understand why it's important to have it. I do not feel like we have, to Michelle's point, solved the actionable ability in the public health sector from STEM to STEM to do scale at volume, where you're doing the whole world and not 35,000 screens a year like we did for Ebola, and where the information is rapid, timely, accurate, complete, and actionable to a public health department. That proof of that remains to be seen, and this committee can reiterate the challenge to do that better in 2005 by taking advantage of contemporary digital tools. We need to be able to filter, pass through, and sort and risk stratify so that a health department already challenged by a pandemic could actually decide how to lay eyes and ears and a light touch digital format for filtering out who's at risk and needs to be managed quickly, and who, can be managed with less intensive sort of engagement. So I agree with Michelle and others. We have not solved this problem, but we have come a long way on the may we and can we side in the federal transportation space, not so sure in the public health response space.
Thanks, Marty. I'm going to take the hands we have raised now, and then before we move on to the next panel. So that's Anna, Bradley, Marcy, Lonnie, and Stephen, is your hand back up again? Okay, and then Stephen. And then we're going to move on to the next panel. So Anna.
Yes, thank you, Gary, for your presentation. I wonder if you could say, given your experience now and everything behind you, the successes and the failures, what would you say is the 1 or 2 primary lessons learned, given that the task of this committee is moving forward? What are the major lessons learned, especially in the early stages of a pandemic where we don't really know what it is, how it's transmitted? From an operations point of view, what would you say to our committee are your major takeaways from this? Gary, I think you're muted.
Yeah, I just did what Clive did, didn't I? I just didn't want to make any noise while you guys were talking. So I think you just have to have that capability ready, right? And that's where I think we've struggled a little bit. And it was a real patchwork when we had to first do the screening for the U.S. persons coming from China. We had some contract folks. We had some DGMQ folks. We actually had some Coast Guard corpsmen out at certain airports just to fill in until we could get the contract up and running. So I think wherever we end up, I think you want to have that capability sort of in a what people would call a warm start capability at the ready all the time. And whether it's by CDC, it's by us on behalf of CDC, however that works, I think that's where you need to be. Marty, many of my people did not sleep that Super Bowl weekend to get that up, and it was imperfect. I'm not sure we got everybody that first day, and it took a while, but we know how to do this now, and I think we'd be foolish to let those lessons go and let the capability atrophy, because I don't think, I read the papers just like everybody else. I don't think that we're going to be done with this with worldwide public health issues. So that would be the first one, is that build on the lessons, don't let it atrophy. The other piece is that I don't know how you go against this, but Marty alluded to it. Clive's done some reports on it, but it was just hard. We were doing temperature checks, and it turned out that they weren't really indicative of anything. So you kind of go with what you know. So I don't know how to improve that, but maybe I don't know what the answer there is. But the lesson learned was that we really were doing a lot of work for nothing, ultimately. And in the real world, once you start screening for something and people accept that, it is hard to turn it off. And it was a struggle to move towards a different regime, even though we had good CDC data that perhaps was telling us that the screening was not as effective as we'd hoped it would be. It was still very hard to reallocate those resources.
Yeah, thank you very much for that. I think that's one of the things I'm hoping our committee will do, is really take on the issue of meaningful screening, because, we knew that temperature checks weren't the best thing to do. Doesn't mean you won't pick up somebody who's got a fever, but all kinds of reasons people have fevers. So let's just put that a little pencil in that, and something we might want to think about as we go through our discussions. Bradley.
Gary, thanks so much for your presentation and your work throughout this pandemic. I've got a couple questions about, one is, could you talk a little bit about how the screeners that you contracted worked with CBP, OFO, Customs and Border Protection? office field operations, kind of how is it operationalized at the POE? And then another question is, could you talk about how CWMD interfaced with, or how did you work with TSA, Transportation Security Administration, to help them implement the security directives that were implemented, and what role did that play?
Yeah, so on the, so we had, my office, CWMD, actually contracted for the folks sort of on behalf of CDC and CBP. So I had folks that were out at each airport that served as the interface between both CDC and CBP. And I saw someone flash as CBP being Customs and Border Protection, the folks at the ports of entry from the Department of Homeland Security. And so that was the interface. Certainly, you know, you get to know everybody, and certainly the contractors were working with the CBP, but the general, you know, the chain of command was through the CWMD contracting officer, contracting, whatever the right term is, to CBP, and that's how we worked it out. So we always had one of our government folks was at each airport, sort of overseeing the contracted screening. Does that make sense? And then yes, and we worked very closely with TSA on both putting out the original security directives for the first, you know, China travel restrictions, and through EU. We had a really, I think we called it the Transportation Security Group, but just a very tight government interagency group. TSA, CDC, CBP, HHS, CDC, DOT, FAA, and we met regularly all the time to work through all of these issues, contact tracing, the 212F restrictions, enhanced entry screening, picking the funneling airports. It was all, and we also likewise met regularly with the industry as well to make sure that they understood where we're headed. So,
thanks.
Thank you,
Yep.
Marcy.
Yeah, hi, it's Marcy Layton. I'm currently with the New York City Health Department, and actually, someone already asked the question I was going to ask, but I thought I would respond to Michelle's first question about contact tracing, mostly because, you know, both for Ebola and definitely with COVID, the responsibility for contact tracing once people enter the US is at the state and local level. So I've been involved with that both during the Ebola outbreak and currently. And I will say, and I hope there's more chance to talk about this during the committee, is I do think we need to evaluate the effectiveness of it. Obviously, a lot of people coming through, their only risk is coming from an area where there's transmission. And once COVID started to be identified here in New York City, we really needed to focus our efforts on people we truly knew were exposed. That was true during Ebola too. And you know, it's a tremendous resource to get up a large contact tracing operation. That said, I feel like the most valuable thing, the two most valuable things that I always take away from these experiences is the need for really good contact information, which I think has gotten better over time, but also the value of just providing information to people as they pass into our country about what you know, the concern is, what they should do if they have symptoms, and who to contact. So I'll just stop there and hope there's opportunity to come back to this, since my question mostly about operational challenges was answered, and I know we're over. So
Thanks, Marcy. Lonnie.
Thanks very much, Gary. Thank you for your presentation. So this question maybe is for you or other CDC colleagues on the call, and it goes to the idea of preclearance. So how good is preclearance? So before people get on a ship, before people get on an airplane, you know, they're coming from all over the world. So obviously there's a quality control issue, and how much work is being done, who's doing that, how much information is shared for this preclearance idea. I was in agriculture for a while, and we shifted a lot of resources to products before they even started their process of coming into the US. So who's doing that? How good is it? And isn't that a strategic part of overall strategy?
So a little term of art there. Preclearance is actually a CBP program which operates in a couple of countries, which means you are actually cleared on your customs obligations prior to arrival. just to clear that because I'm guessing that's not what you're talking about. But I would offer that we do have some things, and I'll certainly yield to Marty on the details here, but we under the global testing order, you have to have a test, and the airlines verify that you've had a negative test prior to boarding the plane to come to the United States. And they will not board you if you do not have the appropriate documentation for that test. And now we have put in the vaccine requirement. And unless you're one of the very limited exceptions, you all have to show a proof of a CDC acceptable vaccine prior to boarding, or the airlines will not board you. So Marty, over to you on any other pre-clearance things you might want to add.
No, I think Lonnie is spot on, which is we've worked through these concentric models of yield. And just to Marcy's point, it's very hard after arrival with the way flights are stacked and diluted to actually tease out exposure and risk to risk stratify appropriately. So we end up with huge volumes. Even if you had accurate and timely information, you've diluted the yield and made the challenge for public health, especially at the local level, enormous. Everything that can be done upstream close to the source should be done that way, which is why we've taken a big pivot in the regulatory posture to have airlines engaged as partners to set a criteria for checking. So our mask order, our vaccine, proof of vaccination, pre-departure testing, all of that, as well as education and expectation setting, the yield is much higher to move it as close to the source. Now that's fine when you have a single source. So again, a pandemic emerges in multiple stages, like the Queen's Gambit. There's an opening act when there's only one or two countries maybe at the source. When it's globalized, now you're talking about an international system that needs to be in place that prevents exportation, when for several hundred years, it was always a country's responsibility to protect itself from importation. So that's a paradigm shift in thinking, and one that WHO and others have to be brought into, but that's where the best yield is in terms of encouraging selective safe travel without unnecessarily interfering with flow.
Thank you. And our last question, Stephen.
Sorry about that. I had to unmute. I'll be really quick because one of our charges is to look at the quarantine station network. And so I guess, Gary, what I would ask is from DHS's perspective, was there much of a difference in terms of dealing with this based on whether or not there was a quarantine station present within a specific airport, or did it work better that way, or did it not ultimately make much of a difference?
No, it absolutely worked better. And in fact, we had to share them in a couple places. The proximity was such, but if there was not a quarantine station at the airport, then you're trying to get people on the phone, and we have got countless examples of where it just worked hand in glove, Dulles Airport being one of them, where we had the Ebola experience, and those stood up so much quicker and ultimately just performed better because of the relationship that was already there, plus the expertise was there when you needed it. Because remember, when you're screening, you're also trying not to create another congregate setting. So any delays as you're waiting to resolve an issue, that just is not where you want to be. So having the quarantine or the DGMQ folks on scene was invaluable.
Thank you. Folks, Michelle, we're going to have to move on. If it's okay with you, we can just hold that question and maybe you can get it unless it's something you really need to answer.
It's just a real quickie. I think it'll be helpful.
Go ahead. Go ahead then.
Just, do you or Marty think that you need more quarantine stations where there are egregious lapses?
I'll yield to Marty on that one. I think they probably need more folks doing it because those people are pretty worn out at this point. And every time there's something more for them to do, whether it's spot checking the new requirements we have coming in, or even, work with Clive when the UN General Assembly what's going on and how do we check some of the folks coming in there, and they're just running out of folks. I will just put it that way.
Okay, thank you. And we can explore that further as we go on.
Yeah, happy to answer another time, George.
So listen, thank you very, very, very much for being here, Gary. We really appreciate that. That was very informative. So it's now my pleasure to introduce the next speaker session. Well, we have 3 speakers from CDC's DGMQ. They'll provide us with some input on the work that they do at and beyond the border to protect health. So we have Clyde Brown, who's the chief of the Quarantine and Border Health Services at the division. Francisco Alvarado Ramey, who's the chief medical officer of Quarantine and Border Health Services, and Andy Clevos, the regional officer in charge of Quarantine and Border Health Services. So with that, I think we start off with you, Clive. Thank you. And if you are speaking, you're muted. Clive, we still can't hear you.
Okay, can you see my screen?
We can see your screen. Yep,
Yeah.
and we can hear you now.
Thanks. Yeah, the button was hidden when I shared my screen.
Understand.
But
yeah.
Clive, it's not in presentation format, so you might want to put it in
It
now.
is not. Okay, thank you. Is it now?
Yes, but go up to display settings and change it so it's because we're seeing both your notes in your
Settings,
swap presenter. I think you do swap and then it will. Yeah, there we go.
Okay, thank you very much. So thanks very much, and thanks, Gary. Again, I reiterate that partnerships are key to what we do in our branch. As was indicated, I will also have my Chief Medical Officer, Francisco Alvarado Rami, and one of my regional officers in charge, Andy Clevos, presenting with me. And I'm gonna go a different route and really focus on the impact, to Gary's point, that the response had on the staffing and our ability to respond and support sometimes multiple activities occurring at the same time. So I'll give you this quick outline. We'll speak about our mission and culture. We'll not really spend a lot of time on legal authorities because Brian and Jennifer did that last week. We'll talk about some of the quarantine station and team activities. And then that one of the quarantine stations will be done by Andy, and Francisco will speak about the teams, and I will try to wrap up at the end. So as was mentioned last week, the primary authority for CDC to enact certain regulations with respect to the introduction of communicable diseases into the United States is delegated to the CDC director. And most of those are delegated to Marty, the CDC's director, to us. The quarantine stations actually are responsible for executing those on a day-to-day basis. So just for your import, these are the current 10 communicable diseases that we have authority to institute isolation or quarantine orders for. Measles, you will know, 2021 was just put in place a few months ago. But beyond the communicable diseases, we have broad public health authority for diseases of what we call public health concern. And so we will take actions related to diseases depending on the nature of the movement, whether it's individuals or importation of animals, for example, with relation to rabies. So the mission of the quarantine branch is to protect the public's health at US borders and beyond. The beyond part, we mean both internally and externally to the United States. So internally, of course, our partnerships with CBP, CWMD, state and local health departments, and other airport partners, especially the airlines. Then externally, internationally, we work with certain ministries of health and also bodies such as WHO, PAHO, ICAO, and other organizations like that. Preparedness is a major part of what we do. And so we have a preparedness team that works with our various partners to put plans in place depending on the communicable diseases to ensure that our ports of entry and teams are able to respond. We enforce the public health regulations. Partnerships, we already said, is a key function of what we do. We respond to illnesses, travel-related illnesses, literally on a day-to-day basis beyond COVID. Before COVID, of course, there was Ebola. On a day-to-day basis, when there is during what we call peacetime, TB is often the disease of most importance. And then we also support public health at other international borders, working with other parts of CDC. So this is what our current structure looks like. Kind of split it in two sections. So there's an operations arm where our quarantine stations fall onto. So currently there are 20 current quarantine stations. 2 of them are actually land border crossings managed by our sister unit called the US-Mexico unit. And then the other 18 are the airport locations that we have mentioned. Those are managed by an officer in charge. And then each of those are grouped into what we call regions. And the region is managed by a regional officer in charge, Andy being one of those persons. The quarantine stations are supported by various teams depending on the type of response. So for importation issues and animal issues, our zoonosis team, we have a quarantine and travel epidemiology team that supports some of the illness response and other issues. And then, of course, communication is a big part of what we do. Francisca is going to go through those in a bit more detail. Now, I'm going to ask your indulgence. I'm actually going to divert a bit to look at another function, which I don't think the last time the committee looked at this was a function. We actually also do our release of 3 medications, artesunate, H-botulinum, and diphtheria antitoxin at our airports. But the important thing here is actually what we learned when we were asked by the malaria branch to expand distribution of artesunate. So at that time, IV quinidine was the drug of choice. It was FDA approved, available in the hospital as an anti-malarial. It was the only FDA-approved drug available in the United States at the time, although artesunate was the preferred drug worldwide. Starting in April 2019, we think for economic reasons, quinidine was no longer going to be available to treat severe malaria. And there are approximately 300 to 400 cases of severe malaria in the world. So the malaria branch was then going to start releasing our IV artesunate under an IND from the FDA when quinidine would have been removed. So they asked the quarantine branch to distribute the 300 to 400 courses versus the 50 we had been doing for quinidine. So we're going to go to 300 and 400 for artesunate compared to 50 for quinidine. So we started to then, if we were going to do this, what would we need? So we reviewed the distribution of severe malaria cases in the United States based on data provided to us from the malaria branch. We looked at distribution by station, time of day, where they were distributed from. We looked at flight duration and drive times to see, what would be the most optimal arrangement to get drugs to a hospital from a quarantine station, and we set our target of about 8 hours. One of the things we wanted to look at was what would the impact of this additional release be on what we were currently doing. At the current time, we had 9 stations that were releasing quinidine, and most were distributed by air, but some also meant people could drive to the local at the airport to pick it up. So we did some fancy analysis, thanks to Brad, who is on this call, to look at the impact of distribution on the time to distribution compared to other activities that were being done by the quarantine station. So what we found was that about half of our releases actually occurred after the normal workday, which means that staff needed to return to the quarantine station, and the vast majority of them occurred between midnight. So there's this gap after the workday, but up to about midnight where half of our releases were occurring. If we were to add the expand to 300 to 400, we were gonna have a significant impact on the workload of our quarantine stations. And we looked at Chicago, which at the time was the busiest station for drug release. That impact was also going to be greater. One obvious thing was that we found a gap in that at the time, Dulles Airport was not a drug release station, and about 14% of our releases occurred in that area, second only to New York State. So one of the things, when we presented this data to Marty, and we were in discussions with Marty, it suddenly hit us. We at our quarantine branch, and I think Marty's going to say the same for the division, we have been running a 24/7 operation on one shift, which was severely stressing our staff, etc. So one of the things we did was the obvious one was to add Dulles Airport as a point of distribution, but then we got funding to add a second shift for the airports doing primary drug release. We, however, continued our ongoing evaluation to identify what we are going to call distribution deserts. And a question was asked of Gary, should there be more quarantine stations? So when we looked at the distribution capabilities to achieve our time goal of having the distribution within 8 hours, we identified a massive gap in the middle of the country, primarily kind of the Rocky Mountain areas and related areas. So we clearly needed to make a change. And I won't go into all the details, but one of the things we noticed was that the Minneapolis-St. Paul station actually could take a lot of the workload off Chicago for distribution in that upper Midwest region. And then in the area of the Rockies, the Denver airport was a great site. Now, we don't have a quarantine station at Denver, but for those of you who were on the committee, Denver was actually slated to have been the 21st quarantine station had we gone past 20. So one of the things we did here was to co-locate, working with the state and local health departments, 2 staff members, a term limited staff member, and a program that CDC has called the PHAP program. And they have been based there, and the health department has worked with us to effect the distribution of artesunate. Now, why I'm saying this procedure and evaluation pointed out 2 big things to us. One, we need to operate on more than one shift in the quarantine branch. And then 2, we also probably need to look at other arrangements, working with either state or local health departments or other partners, where we are able to pay to post staff in areas to kind of expand. That relationship with Denver was crucial in some of the evaluations that went on for COVID-19. Some people may have remembered in the news where some people who went on ski trips were actually identified with COVID-19. And having somebody there working with the health department really was helped us to get that investigation through quickly, etc. So I'm going to hand over there to Francisco, but just this final, sorry, to Andy, but just to look at this map, after we made those changes by adding Minneapolis-St. Paul and adding a staff member at Denver, this is what our distribution desert looked like. Not perfect, but we mostly have now accounted for being able to guarantee distribution in a relatively majority of the United States. And then just want to show you the impact on our staffing. So we have been able to increase staffing in the branch thanks to our administrative team. CDC is the fourth largest branch at CDC if we count federal staff only. If we count the number of contractors that we've added on, we are the second largest branch. But we still have a huge and massive deficit in being able to fill those positions, or unfortunately, in truth, many people have left over the past 2 years. When people leave, I try to take the opportunity to read some of the comments they make. And I think I can be safe in saying that 100% of the persons who have left have commented it's because of work-life balance or lack of work-life balance. They have been working so hard for so long, and especially if situations come up in their families where there's some added role taking care of a mother, grandmother, or other, or I had a child, persons are finding it difficult to maintain the level of support for their families that they make. And I'm going to leave this section with a quote from one of the persons who left, a relatively young person. She said she loved working with the quarantine branch, but her comment was, when you work with the quarantine branch, you have to be prepared for anything, in bold caps. Then she went on to say, it's like playing football, but you're playing both offense and defense for the same team for all 4 quarters. So, you know, my team, my family, my quarantine branch colleagues have been severely impacted by this outbreak, more than they ever have. And we need another structure for how we put the quarantine branch together to ensure that people have a work-life balance and can continue to serve us, but they also need to serve their families. Andy, do you want to present separately, or do you want me to change slides for you?
Yeah, if you could just keep on. Well, first off, can you hear me all right, Clive?
Yes, I can.
Okay, perfect. Yeah, if you could just keep on clicking the slides, that'd be really helpful. So good morning or good afternoon, everyone. I'm Andrew Clevis. I'm the regional officer in charge, and I am actually field-based. I'm not in Atlanta. I'm based out of Miami, where I've been here since 2011. And before that, I was up in the Boston quarantine station, where I initially started with the branch about 14 years ago. So I'm going to give you a brief overview of where we are, how many we are, and what are some of the activities that we've been engaged with as a part of our core functions, as well as some of the highlights that we've engaged in recently, where we've had to surge towards different activities that have demanded our attention. So in this slide, you'll see our jurisdictional breakdown of where our quarantine stations are located, largely all at large ports of entry, strategically placed to capture a large volume of the international arriving traffic into the United States. In addition to the CONUS, or the continuous United States, we also have quarantine stations located in Honolulu, Anchorage, Alaska, as well as Puerto Rico. And if I didn't have this background filter on right now, you can see out my back window and you can see Miami International Airport behind me, but the light doesn't work that well. But what you do see in my background is actually one of the subports that one of their stations actually oversees. This is the port of San Juan in San Juan, Puerto Rico. And I took this picture on one of our visits there not too long ago. So as you can note in this slide, that our stations not only, you know, have a big piece of work when it comes to just maintaining the operations at the ports that they're co-located at, like Miami, at Miami International Airport, but also they're responsible for all subports and activities within their jurisdiction. So just to continue on the example for Miami, Miami supports all ports of entry within the state of Florida, Alabama, and Mississippi. And this is also inclusive of airports, so large and very growing airports, especially since the stations were established in Orlando, Fort Lauderdale, and Tampa, but also all the maritime ports that have also grown significantly over the last couple of decades, including the Port of Miami, Port Everglades, and Port Canaveral, just to name a few. Likewise, for all of our other quarantine stations, they also oversee all of the subports within their respective jurisdictions. Next slide. Here is a breakdown of the kind of continuing on the last slide that Clive highlighted, our staffing breakdown at each of the quarantine stations. So who's comprised in this number? This is operations staff. This is the officer in charge, so the lead public health person at that quarantine station. There's also regional officers in charge that are typically field-based, more often than not, co-located at one of those stations, along with our quarantine public health officers. And so you can get a good sense of what the staffing breakdown, and I'm just going to walk you through this slide. The first column is our permanent staffing. These are the people that, to borrow a reference earlier, that would be here during peacetime and during response operations. They're the core set of staffing that are holding down the fort at all times. Current staffing is on the left-hand side of that permanent column, and then approved positions. So you can see that across all of our stations, and again, kind of going to a point that Clive highlighted earlier, we constantly experience a significant level of staffing churn at our stations. So we're always kind of working to keep up and making sure that we're at least at our base minimum staffing that we're actually outfitted for. The next column is our term staffing. And these are temporary staff that we've been able to hire on, many within the past 2 years due to COVID, in our expansion of our border health operations at these quarantine stations. These term staff have been able to come in at various roles of officers in charge at some of the stations that were de-staffed, i.e. like Dallas quarantine station and Boston quarantine station that were stood up in response to COVID-19 screening operations at those airports, along with quarantine public health officers who go and help to support that operational staffing rhythm. These are term, and so they are tied to a timeline, and so they will not be the ones that will always be able to be there in that position because they are that funding is tied to a specific timeline. Overall, in the last column, you can see the total staffing, both permanent and term put together, and you can see that we are working through many challenges and making sure that we can try to get to our baseline of staffing, both because of that churn and difficulties in recruiting, hiring, and onboarding our staff. Currently, we're sitting at about a negative 46% below what we should be at with our baseline. Next slide. So now let's go into some of the core functions that we have. So of course, we respond to reports of illnesses on airplanes, ships, and at land border crossings. We also, as Clive highlighted, we are points of distribution for life-saving drugs. And then we also provide travelers with essential health information. You can see some of those activities highlighted in the pictures at the bottom of the slide. We have travel alert monitors at many of our ports of entry where we have quarantine stations, and some where we don't have quarantine stations, to just kind of get the public health messaging out in a rapid form that allows us to be kind of adaptive to some of those challenges that are coming up constantly. Next slide. Continuing on with some of our other activities, this is kind of getting into some of our regulatory review and functions at the quarantine stations, including inspections of animals, animal products, or any other potential vectors that could be containing communicable diseases that would pose a threat to human and public health. With that, we also inspect cargo items, hand-carried items for any of those vectors. Big part of our work, especially during peacetime, but it's a constant rhythm, whether it's in peacetime or response operations. We're constantly planning, preparing for emergencies. It's a little bit easier to do when we have big events going on. We always are able to grab people's attention and kind of direct them to the importance of public health and their role in public health. And a lot of that's done through communicable disease response plans at ports of entry, where we work with a large set of partners, all who would have a critical role to play when it comes to responding to communicable disease response emergencies. We also monitor the health and collect medical information for immigrants, refugees, asylees, and parolees. We respond to mass migrations emergencies. And of course, and this kind of goes hand in hand with the planning and preparing for emergency response, we build partnerships, which are absolutely critical for us being able to maintain a surveillance and response mechanism, especially given the staffing numbers that you're seeing in the large jurisdictions that each of these quarantine stations is charged to oversee. You know, clearly with the staffing footprint in the single digits, we aren't able to project an in-person or a presence to a lot of these subports or even to the co-located ports. So a lot of our ability to see and respond is working with our partner agencies to kind of project our ability to identify and subsequently respond to, and also enforce our regulatory overview or purview on some of these specific items. Next slide. So here's just a snapshot of some of the partners. There's some that we did miss on this, including some of our law enforcement partners from the Department of Justice, FBI, U.S. Marshal Service. But our big partners are up here, the CBP, Customs and Border Protection, DHS, our other federal agencies, including USDA and U.S. Fish and Wildlife, where we work with them at our ports of entry to help enforce our regulations, Coast Guard and Department of Defense, as well as our state and local health departments, some of our most critical partners wherever we're located. And so a big part of what our quarantine stations officers do on a daily basis is work and liaise with each of these agencies, working to make sure that we're up to date on our emergency preparedness and that we're in constant communication so we can make sure when items do come up, we're ready to respond and work with our large set of partners as seen here. Next slide. So I wanted to highlight two examples of some recent activities that have been kind of drawn up from our core functions, but required kind of a special emphasis, if you will. The first one is OAW, or Operation Allies Welcome. This is in response to the recent Afghan evacuation that started in August and is still ongoing. In response to that, CDC work to develop guidance and protocols and leverage our existing partnerships at the quarantine stations that were identified as funnel points for the arriving Afghan evacuees from Kabul and the lily pad sites that they were staging from. CDC stepped up its response by surging additional quarantine and deployer personnel to 3 specific airports. Initially, was all flights were coming into Washington Dulles quarantine station, or the international airport, and then subsequently to the Philadelphia and Chicago O'Hare airports as well. We screened, I think, in excess of, or I think over about 124,000 evacuees arrived at CONUS. I think that's an underestimate. And we worked to establish public health screening. Quarantine station personnel specifically were handing out masks, conducting visual surveillance, and working with our partners to establish a testing protocol at the Dulles International Airport and Philly International, or Dulles International Airport, to conduct testing to confirm any illnesses that were identified in the evacuees that were moving through those airports. And then we would conduct further illness response and work with our partners, including DHS, health department staff, initially the Virginia Department of Health, because we're working out of Dulles, and then the Philadelphia and Pennsylvania Departments of Health, as well as the Illinois Department of Health, to work with any of the U.S. citizens and legal permanent residents that were going to require quarantine and isolation, and then DHS for all those falling into a visa category or non-visa category that would require federal support for quarantine isolation for the duration of that period. Next slide. Another big function that we executed soon after we started setting up screening at our ports of entry for COVID-19 was in response to the repatriation activities that we conducted initially at the Anchorage quarantine station and then at some of our Air Force bases, including Travis Air Force Base, where we were receiving repatriates from Wuhan, China, and later on maritime vessels in the Pacific region that were experiencing COVID-19 outbreaks, and working to get our permanent residents and U.S. citizens homes to the United States, and doing that in a safe manner. CDC, again, surged its personnel and worked with our partners. In this case, the ACF, Administration for Children and Families, ASPR, Department of Defense, of course, at the Air Force bases, and then the Marshal Service, the law enforcement component, to help support enforcement of our quarantine periods that we were placing on all the evacuees or the repatriates coming from these affected areas. We again worked to set up a screening mechanism, health declarations, visual surveillance for screening, including temperature checks, and then helping them and our partners kind of facilitate a quarantine and isolation period where when it was required. Next slide. I think I'm going to hand it over to Francisco to continue the presentation. Thank you.
Thank you, Andy. Good day, everyone. I too look forward to the insights from this committee on ways to advance our mission. There's much to leverage from the developments since the last Academy report. I think looking through the lens of what we know now and have now is clearly different from our circumstances in the first few days of the pandemic. Now we have more accessible testing, vaccines becoming available globally, and we know about asymptomatic transmission. So these developments are allowing policy actions to begin addressing the deficiencies of port of entry interventions, which reflect a snapshot and have sensitivity and specificity challenges. So with COVID, there's an unprecedented appreciation of the public and industry, for that matter, about border health and quarantine. And many sectors of the economy are benefiting from the adoption of new technologies. So innovative technologies can be used to facilitate that all international travelers know what to do if ill and can link with their local health department, an intervention that Marcy was alluding to earlier. My objective today, as Clive and Andy have tasked me, is to share an overview of the teams within our program. Our quarantine and travel epidemiology team has a focus on epidemiology and response related to conveyances. The team is composed of 3 activities: the air activity, which coordinates and establishes procedures for our response to illness and disease exposure during air travel. In this role, they work closely with airlines and state, local, territorial health departments to enable contact investigations. Similarly, yet acknowledging the different contexts in terms of duration, resources, and speed, the maritime activity responds to notifications of illness and deaths aboard cruise and cargo ships. Cruise ships account for most of their caseload in approximately an 80-20 split. Besides health departments, the activity works closely with cruise lines and shipping companies. The third activity within the team is a travel restriction and intervention activity. This activity handles individual level federal travel restrictions. Unlike the no-flight list, this tool is strictly for public health purposes. The do not board list and the issuance of a accompanying public health lookout represent an innovation that grew out of experience when managing individuals who pose significant infectious risk while disregarding public health advice. All 3 of these activities involve partnerships with the Department of Homeland Security, specifically Customs and Border Protection, and you heard Dr. Rasicot speak about our partnership. The team strives to contribute to the body of knowledge by publishing its findings and experience, modifying our own protocols accordingly, and participating in meetings organized by international bodies to issue recommendations for risk assessment and management for exposures that occur or related to conveyances. The quarantine and travel epidemiology team also issues foreign public health notifications as per our responsibilities under the international health regulations. And unlike most of CDC programs, ours carry the added duty of administering and enforcing regulations. Next slide, please. Here we have a summary of CDC travel restriction actions since 2018 through early 2021, through early November 2021. DNB stands for do not board. You can see the tremendous growth caused by the novel coronavirus, an increase of 17 times above the baseline before the pandemic. Travel restriction actions, which begin with a consultation request by a health department, have more than doubled in 2021 compared to 2020. This growth is largely due to increase in testing availability and proliferation of testing services in support of the traveling public, often located on airport premises. Next slide, please. This chart shows the number of illness and death reports sent to CDC by health departments and other partners during the first 3 quarters of 2021. Depending on a set criteria, our staff determines which ones merit initiating an air contact investigation. Even if many do not end up triggering a contact investigation, just the sheer number represents an enormous burden on our staff who triage these reports. Next slide, please. Next is our preparedness and policy coordination team, and they manage several key functions for the branch. These include preparedness planning, including continuity of operations, concept of operations and all hazards plans, exercise development and facilitation, after action reviews and improvement plans. And they also provide policy support for the branch when we have questions involving policy and operations and staffing support. One recent example is the Operation Allies Welcome Andy just referenced, where they coordinated travel for more than 200 response personnel. Besides overseeing preparedness planning internally, they provide support to airports developing their own communicable disease response plans. And just in 2020, they assisted in the validation of more than 30 such plans. Next slide, please. Next is the zoonosis team, and their mission is to prevent the introduction and spread of diseases of public health concern from imported live animals and cargo to humans. The team routinely conducts non-human primate inspections throughout the nation. They also provide subject matter expertise for quarantine station staff regarding live animals and animal products, human remains, tissues and human products, infectious biologic agents, and vectors of human disease. Next slide, please. The zoonosis team has responded to an increasing trend in dog import denials. In 2020, there was a 50% increase, followed by a 1/5 increase in 2021 over 2020. Given the increase in falsified documents, the number of dogs arriving ill or death, and the outside demands the pandemic has placed on health departments, CDC issued an order in July 2021 suspending entry of dogs from high-risk countries into the US unless an exception applies. And this suspension is foreseen to last approximately 1 year. Next slide, please. Okay, previous slide. There you go. So because China has imposed a ban on non-human primate exports that occurred in January of 2020, non-human primate imports from China have ceased. On the other hand, imports from Cambodia are increasing as importers address the shortfalls from the Chinese action. This shift has resulted in smaller and younger non-human primates being imported, which means an NHP population prone to sickness and death during the importation process or more vulnerable to it. This added morbidity has placed additional demands on the zoonosis team personnel. And also on the COVID front, this team has been monitoring the emergence of SARS-CoV or of a SARS-CoV variant from the mink population, and also has supported wider CDC risk communication efforts around this topic. Next slide, please. Our communications and training team plays a crucial role addressing information needs from the traveling public, our federal partners who help enforce many of our regulations, and our staff. During COVID, our personnel, mostly through contractors, swelled about 5 times, yet our communications and training team only gained 2 term-limited positions. So this scenario forced the team to change communications and training methods. Next slide, please. So to match the urgency of the pandemic response, the training activity specifically transformed internal trainings from e-learning modules, each taking months to create, to more of a multi-modality instruction that could be developed in days. New trainings have included live webinar, which we record, job aids, practice scenarios, and a required test. Because our staff are located across several time zones from Atlantic to the Hawaiian Aleutian, our trainings are typically offered in 3 separate shifts. And I think next slide, please. The media and communications component of the communications and training team has been particularly busy during the pandemic. They coordinate media responses, revisions to our travel alert messages posted electronically at airports, which includes also translating them into the appropriate languages. Their portfolio encompasses a cross-cutting work of our program. And in 2021, it included communication products on mink and risk of SARS-CoV spread, the dog import suspension, and a wide range of messages supporting the Operation Allies Welcome. Let me point out that because of time constraints, I'm unable to present on our epidemiology field team and our resource support services team, as well as on our surveillance activity. Let me turn it over back to Clive.
Thanks, Francisco and Andy. So, I think you can see that the quarantine branch does a lot of activities with very limited staffing, and we have challenges maintaining our staff. So this is a slide that Brian showed when he presented last week. I just wanted to return this slide so you show the impact of what happened over the period. And you can only imagine what happened on that March period when we added the Schengen area to the screening activities. I want to just answer one of the questions that was asked of Gary. So whenever we have anything that's going to involve screening, the quarantine branch staff put together a concept of operations that includes the screening criteria related to the symptoms or signs for the disease of interest. And then we would share that with Customs and Border Protection, and in this case also with the CWMD leadership. Now, Gary did not mention, but I was speaking to 2 or 3 of his staff members literally every day when we were gonna set these processes up. So we are in constant communication, we change notes, and we make modifications to our approach based on input from our partners. I'll also say that when we do our trainings, we train all of our staff, the training team that Francisco mentioned, and CWMD staff were open to join those trainings as well. So we try to make sure that everybody is operating from the same playbook. I'm just going to show some graphs, and I think they speak for themselves. the impact of the COVID outbreak. So this is the typical pattern we saw from 2005 to 2019. You know, the 2014-15 blip was Ebola. We thought that was going to be as bad as it would get, but clearly the COVID response has dramatically increased the impact on our staffing. Similarly, these are just a subset of what Francisco presented for the travel restriction team. These are the actual additions that the team has done for various diseases, and clearly COVID-19, the gray bar, has outstripped all of the other diseases for the past 2 years. I spoke to drug release earlier. So in some respects, that has not dramatically increased due to COVID. There was a dramatic increase in 2019 because, as I mentioned, we shifted to distributing artesunate because quinidine was no longer there. But you know, the decrease in artesunate distribution in 2020 is that malaria branch actually found troubling, because what their analysis suggested to them is that because of fear of going to the hospital because of COVID, there were fewer people. Now, their original thought for me was that there's decreased travel, but actually, since Africa was not one of the original targeted countries in what we call the 212F, the volume coming out of Africa, especially when persons from the US were returning home, actually did not go down, but the visits to the emergency room did. You will also notice a kind of slight increase for botulinism. That unfortunately may be an impact of the epidemic on persons, leading to some increased use of drugs. So just gonna summarize the last 2 slides. So the challenges: work-life balance was a major challenge during this pandemic, and staff retention was a major issue. You know, thanks to CWMD, we were able to stand up some of the functions at quarantine stations, but you know, we still within the branch had many other activities that needed to occur, such as the travel restrictions, etc. And you know, the ability to scale up quickly was very limited. Everybody was working hard, but we weren't on the part of CDC needing new and additional staff. It's also difficult to predict, right? You know, you may go by what you needed for the last response, but that is nowhere a good guide for what you will need for the next response. And I don't know the answer to that. So I'm putting that out there as one of the challenges. Something we did not have a chance to go into is, you know, the data systems aren't as integrated and as great as we need them to be. State and local health departments, and Marcy may speak to this, were very frustrated with what they saw as having to report the same thing twice to CDC. Now, the subject matter experts only need to know that a case of X occurred. If it's a quarantinable disease or a disease of public health importance, the DGMQ, we need to know who that person is. So they don't need identifiers, but we do. We need some system where states and local can feed information to CDC, probably with everything that's needed, but with the protections in place so that only those persons who need to find personal identifiers can access them. We also need to find new ways of communicating to travelers. You know, although we have our travel alert monitors in the airports, and also CBP puts our messages on their signs, you know, sometimes we hand out flyers. We don't think that we're in the modern age, there are better systems. Now, we did, with partnerships from some of the carriers, send text messages to persons who, when they came into the US, they were either entering or leaving roaming, and they got a message about what to do, etc. We need to be able to make that a permanent feature, but also to have it targeted, if possible, to people coming from specific countries. Not sure what the answer to that is either, but that's a challenge that we have had. And sorry, just some potential future directions. I leave it to the committee to expand on these. I'll just put these slides up. One of the big thing is we need to operate on at least 2 shifts at the majority of our quarantine stations. Our medical officers, our travel restriction teams, and other teams doing responses. I've also found that trying to do things where you're working overtime, it's sapping the energy and the resilience of our staff. So as a branch, I think overall, we need to be working on 2 shifts for the vast majority of our operations. And then, repatriation was not something we had a small response plan. One of the ideas was that we would train other partners to do things when the repatriation activities occurred. But once there was a base set up, people said, no, CDC, DGMQ has to be there. 1, doing the screening, 2, doing the monitoring, 3, handing out isolation or quarantine orders. So, maybe that's not something we need to do, but if we are going to be doing it, then we need to be staffed appropriately to lend that support. So I'm not going to read through this slide, just leaving it there as some things to consider for activities that may suit our program as we go forward. Thank you.
And thank you very much. I'm assuming that the question that you had got answered. Anna, I guess you had a question about communications. That was in the chat. I think someone had a question about communication in the chat, which I think you answered. Michelle answered. Did you get your answer?
Yeah, it's been answered. Thank you.
Okay. So Stephen, Jason, Ed, Alexis, and Moon.
Let me just start by thanking you for those presentations. It really is so much information and you have so many different responsibilities. It's kind of hard to get your head around all of it. Just a couple of questions. It sort of strikes me that with all of these responsibilities, some of them strike me as a bit non-critical, I guess is the way I would say it. And I'm wondering for things like drug distribution. I mean, I understand why traditionally CDC has done that for certain diseases of public health significance, especially in circumstances where CDC is the IND holder. But having worked at FDA for a number of years, we did emergency drug distribution all the time, and we didn't do it from FDA staffing headquarters. And I'm wondering, for that, have you examined other potential models to be able to do this without having to encumber your own staff that seems to be incredibly busy with other activities? I mean, I'm kind of thinking of whether or not there's some private entity that could help you do this, some courier service. We have the Strategic National Stockpile, although I realize that that's with ASPR. And the other one that kind of struck me with the same type of questions is things like issuing dog permits. And I'm wondering whether or not there's some outside entity that could help you do this so that you can better focus on what I think are probably more of your core responsibilities.
Right. So let me answer the question related to the drug distributions first. So certainly with ARTISNet distribution, that's one of the things working with the malaria branch that we did look at. And when it's a life-saving drug that needs to be delivered in a short period of time, why the quarantine stations were targeted in the first place was because we're out there in the field and closer to hospitals. When they actually, I probably shouldn't call the name, but when they reached out to some of the companies that do deliveries, they actually could not and were not willing to guarantee the distribution times that we aim to satisfy. So if it's a life-saving drug, there really weren't a lot of entities out there. Now, if we then looked at doing it with, let's say, a private entity, and Marty may want to chime in here, the cost was prohibitive. And so if the federal government was doing it, it was not going to be cost efficient, to put it that way, to have some private entity weighing in. But Marty, you want to add anything there?
Just quick answer, Steve. Yeah, we looked into it. We couldn't find any takers in the private sector but if you think FDA is a potential taker, then we'd be happy to approach them as well.
As I said, FDA didn't do the distribution themselves, and they were also for sort of critical drugs.
Yeah, no, I get.
You're muted, Marty.
Marty, you're muted. All of a sudden, we lost you.
Oh, I'm sorry. My mic is showing open on my end, but can you hear me?
Yeah, we can now.
Okay. No, I think it's just unfortunate because that was the first thing we did, is try to find carrier services that have, a 24/7 delivery operation. None of them could could either commit to global coverage or, after hour coverage, basically. And none of them was willing to take the challenge on with regard to having an 8-hour delivery time to bedside. So we tried for several months together with the malaria branch to find another solution. I didn't know about the FDA activity, and maybe we could continue to look at that. The dog permit issue has been a tremendous strain because it's very emotionally loaded. When dogs get here, we've had rabid dogs imported from unscrupulous importers in this time of surge, and we've had a lot of consequence management around that. And yet keeping puppies from returning military veterans or various other folks is very unpopular. So it's generated huge social media burdens on us as well. Both of those things would be very ripe for finding an outsourced solution to.
Thank you. Jason.
Well, thank you, Clive, Francisco, and Andy for the presentation. I noticed that on one of your slides that it says about 46% of the vacancies are unfilled for a variety of different jobs. And I was wondering if you have more background on sort of what are the typical personnel background look like, and what their age, demographics, and typical tenure. Are they stepping stone jobs, or are they career jobs? And how will you sort of target your marketing to fill those jobs? Because if they are on average 46% unfilled, then you have a recruitment issue as well as retention.
All right, so that's a good question. So one of the things I will say is that we may not be the only ones experiencing this. Speaking to some of our CDC colleagues and even state and local public health colleagues, the market is very difficult right now. I know our HR has been working over time, but the sheer volume, even from our program plus other programs, recruiting people is difficult. Now, I will say many of them are what we call quarantine public health officers. And I think I've convinced Marty that we really should look at this more as a intake early level public health training program, and then have a kind of an open door. Don't expect people to stay there more than 2-3 years or as such. Of course, that will only add burden to the HR system as that's already there. But if you look at the graph that Andy showed, many of those were in the NTE area as well. Those are what we call the term limited persons. So those are positions given to us to serve as federal officers. Now, contractors are a bit of a challenge for us, because what DGMQ and especially the quarantine branch does is what we call inherently government activities. So many of them contractors can't do it. So we need federal staff. But the NTE, the term limited positions, people don't find them very attractive. So they will come, it gets them into CDC, but then they see other permanent positions that they then will apply and transition to. So it's a challenge for us, but especially the 2-year NTEs, The 4-year NTEs, term limited positions, are a little better, but unless it's a true permanent position, it's very hard to hold people there. But I go back to the issue of work-life balance. Our branch has been so heavily impacted that people say they love it. They see the public health impact. They know it's important, but gosh, I just can't manage this for any longer. Marty, anything you want to add there?
Just to one other thing, Jason, we did actually partner with the PHAP program, the Public Health Advisory Program, which is kind of an entry-level 2-year rotation. And we expanded that program to have a temporary 2-year entry-level workforce, all of whom will rotate out and then go into other positions, other career track positions. That's been very successful, but that's already been tapped. And I don't know of another similar kind of place where we could get that, perhaps through extensions through schools of public health or something. Over.
Just one quick comment that there may be some lessons from military recruitment as well that you could tap.
Yeah, good point.
Right. All right. Ed.
Clive and Marty and everyone, thank you. I guess one question is, can you compare your 46% to other groups at CDC? Was one question. And the second is sort of bringing more modern technologies. Can you comment on whether, since everybody coming, I'll say on a plane or on a ship, you have access to fecal samples, the sewage system. Can you start applying molecular diagnostics to plane laboratory samples, and/or can you comment on burner phones for a week after somebody comes home? I know you did that with EVD. And can you comment on perhaps working, since you guys are getting burnout, I guess the question is, some of the things, remember all your major ports are in cities with 2 or 3 major round-the-clock quaternary level facilities, hospitals. And so can some of your things be farmed out to those round-the-clock places, et cetera? So I know there's 4 questions in there. The first was, how does your 46 compare to other branches of CDC?
I'll start with that, Ed, and then let Clive fill in some details. I don't think we know that answer yet, but CDC is hurting right now on recruiting and retaining and recruiting. And that's probably a bigger issue. We could probably get that information for you for another meeting. We actually went to hospitals first to explore a combined solution to the artisanate distribution and other things, and that was kind of nixed. That was pre-pandemic in April of 19. There weren't places that were willing to step up. What they basically said is, we'd love to have a cache for our own hospital, but don't ask us to be responsible for delivering to other hospitals that are not our own. That's kind of where that ended, in short. And I would say this sort of general idea of, what was that the third point?
Well, there's sewage and burners.
Oh yeah, on surveillance, we've expanded our approach to travel for surveillance through a series of partnerships that are just about to get started, but they have not included sewage surveillance. It's an interesting idea. We did make that recommendation to the cruise ship industry in addition to the crew and the passenger surveillance. But it's something that would be worth looking into as a more efficient approach. And on phones, we've resurrected the phone model and have found donors and have given phones to some large portion of the 100,000+ Afghan evacuees have all been getting phones. Our activities start at the port of entry, but as you'll hear on Wednesday from Nina's group, we've been staffing the medical screening and intervention assessments, vaccination programs at the 8 military bases, CONUS as well, where there's been a rough census of about 70,000 across each of these 8 bases. 50% are children under 18, and a third, are women of childbearing age. So lots of special public health challenges in those, but the phones are a very useful way to make continued contact. Over.
Thank you. Alexis, and then Moon, and then Ruben.
Yeah. So the question is, in one of the last slide, you mentioned and I think this is quite big as a statement: inadequate tools and capacity. And so when you talk about inadequate tools and capacity, can you provide us some more examples of the details of the challenges? What is that? Is a database issue? What actually means inadequate tools, and especially in terms of what would be a more general the data pipeline and or whatever, aside what you can have in terms of really tools on the ground. And the second question is related. You were showing that slide with the number of people screened according to the different to the travel the issuance of first was toward China, then there was I think Iran, then the European Union, and so on and so forth. Yeah, obviously your travel screening was based on just on the travel history, and my curiosity is how much you are involved in the decision-making process for deciding which countries and what kind of traveler have to be screened.
Right. Marty, you want to take the decision-making part?
Sure. So first of all, those were done by presidential proclamation, the 212F determinations. Those were initiated in the prior administration, as you saw and heard in January for China, and then expanded. We were actively a part of the conversations, but we were not the decision makers on the imposition of the 212F travel ban. But we contributed to the discussion and the debate. And those were done by presidential proclamation. The interagency was then wrapped in entirely across, as you heard from Gary, multiple departments and agencies to issue directives, et cetera. One correction that I'd like to make is that the screening that we initiated, which was even earlier than the bans, was not simply based. So the component was we focused on that early on before there were any travel bans and 212Fs in place. And then we concentrated in those areas where they were large numbers of returning Americans, where the ban was the major way to restrict volume. But it included exposure questions, symptom questions, temperature checks as an attempt. And any of the positive hits on that, as Gary described, would go to our quarantine branch staff at the port to do further risk assessment in order to try to triage and effectuate that yield. In terms of skill sets overall, just in general, we are short on quantity across most of the skill sets. We really need, as Clive said, and I've been saying this across the division, we really need to have a program operation that recognizes that we're working at a minimum at 2 shifts from early AM till midnight across the division. It's easier to see it in the field and try to scale that, but this is the same problem at headquarters, especially for leadership positions. And then there's a wide variety of different skills, and we can give you a breakdown of the type of job descriptions that occur, particularly in the field at ports of entry. But I do think a lot of these things have to be looked at from the perspective of what are necessary human engagement functions and what things can be streamlined through a variety of digital tools. Filtering yield and making contact and having both outreach for education as well as return. There's a lot of digital tools that have been effective at reducing the human burden intensity of trying to see who's really at high risk and of concern versus who just needs to get push messaging and know where to go if they develop a problem. And there's been a number of these developed over the course of COVID that we think really need to be integrated much more effectively when you're trying to screen high throughput types of travel risk assessments. And like I said, I think the bigger problem for a disease like COVID, which is so much pre-symptomatic contagion, is not always about finding the case. It's about really alerting people and educating people on what happens during the incubation period. The pre-departure screen is a very effective way to keep COVID out of the transportation corridor, along with all the other tools, tests and masks and other things. but it's incubation period management, I think, that represents a huge problem in this regard. And it especially will be problematic at the early end and at the sort of bottom end. It's almost impossible to convince and to really attack this during a peak where you have nationwide autochthonous spread. But at the at the upswing and the downswing, when these are under control, it's really important to have good eyes and ears on those risks. Over.
And just one quick follow-up, just to be sure I understand. So you were saying, that obviously your screening was preceding the travel bans. But for instance, in February, however, the screening was based on travel history. So it was from China. So you were focusing on travelers from China. So and then you were expanding this list along with the CDC evidence for outbreaks in other countries. Is that
No, that is correct. I would say that because it was a process that was coordinated out of the White House and it involved the entire interagency, the discussions were CDC had input and was deliberative. But I would also say what I think is apparent now from CDC's perspective is that system of determination, the virus moves much more quickly than the bureaucracy can move in order to be current with that. And so we have pushed for a whole different approach to safe travel that goes back all the way into March and April of 2020. But Gary also alluded to in his presentation, the ability to pivot to something that is more effective, and those recommendations are made. Those determinations of when and how to pivot are not CDC's alone, and they're often harder to let go of than they are to initiate.
I will also add to that. Marty mentioned the things we do at screening, but a major component was collecting the contact information, because up to that time, there was zero way of identifying the persons. As Marty said, we're not going to identify people necessarily unless you're obviously ill, and they should not have got on the plane in the first place. But people may be incubating, and as we may want to pass that information to state and local health departments. Up to that time, the only way to get that information was by collecting it when people arrived. Over.
We need to move on. Thank you very much for that. Moon?
Hey, thanks CDC and Clive, Marty, for your presentation. I had a question about the maritime sector. And so are there any requirements or best practices that are currently going on with CDC in the maritime sector, for example, vaccination requirements with cruise ships or cargo ships that remain challenging in the future that you feel that should continue? And then my second question would be sort of what you touched on, but I was wondering if there's specific resources that you would like to do in the next pandemic, given the pre-symptomatic and short incubation period, that specifically you'd want the 20 quarantine stations to do and work on right when the pandemic starts early on, specific things other than resource intensive passenger screening activities.
Yeah, let me start for both of those, and then Clive can add on. So first of all, in the maritime environment, the beginning of the pandemic was the hallmark was that we were just beginning to learn a lot about the virus itself and transmission as a result of maritime outbreaks, particularly Diamond Princess off the coast of Japan. We had our own Grand Princess, et cetera. We learned high attack rates. We learned populations of vulnerability. We learned about asymptomatic spread by doing testing. We got into that repatriation thing along with the rest of the world. And I would say that there was this period of time that went on for many months in which the public health awareness of what we were dealing with and the actual awareness of the industry and to what the potential magnitude of cruise ship travel would pose toward outbreaks and dissemination and spread were not well aligned. And it was a contentious relationship between public health and the private sector in that regard. What we really learned was that we needed to be very forceful in using regulatory authority to issue no sail orders and actually stop the amplification and spread and global distribution, and ships at sea with literally hundreds of thousands of people on them and no ports to go to effectuate good response or preventing spread. We did manage to transition that relationship when I think the awareness on how big this was sort of caught on uniformly. And so after a lot of time of no sale orders, we were able to lay out, can we envision a future that's safer travel that allows some industry function without shutting it down completely? And that's when we pivoted to what we call the conditional sale order. That has been extremely effective and has high participation rate. And as Gary described, that evolution of that relationship with sometimes twice a week in engagement and a very large team of CDC maritime responders in order to maintain that. That has been something that has been very useful. The question is now does there need to be a regulatory framework to maintain that partnership, or can a voluntary framework work? And if it can work in a voluntary way, what level of oversight is still required? I can't see us in the very near future going back to a situation where we could deal with the size of staff that we had in the maritime unit compared to what we have now to make that work. So I think moving forward in any pandemic, we've got to recognize there are enormous challenges, not only by moving people around by air, but also in the volume at sea and in prolonged congregate settings. In terms of rapid detection and alternatives to screening, I think we have failed in general to move off traditional paradigms of that filtering out and who knows what. There are a couple of promising approaches to technology, which we've seen kind of scratch the research surface, but they need to be moved much more forward in terms of efficiency of screening at a port or before boarding. For example, the training of dogs or olfactory systems to kind of sniff out and have a higher yield of who may likely be infected that's either pre-symptomatic or asymptomatic entirely. There's been a lot of promising research. Some countries have tried canines at airports in that setting. They're extremely effective at looking for contraband in obscured luggage, and ways that we should be creatively thinking to make the invisible by ocular detection or by temperature screening more visible through other means. And once we get the aromatics figured out, there probably can be, animal independent sniffers that could be more effective, but a lot more should go in to these other types of tools rather than some of our traditional approaches. And we know at the beginning of any pandemic, we're going to be hampered by diagnostics. And so figuring out how we exploit the screening approach as diagnostics are being developed and not waiting for either diagnostics or treatments or countermeasures in our traditional sense has got to be part of our preparedness arsenal moving forward. Over.
If I just add to Marty, one of the things we need to be able to do quickly at the start when diagnostics are available for any outbreak, one of the questions that people want to know, what's the risk of transmission during air travel? And that's usually difficult to do. We need some system whereby we can do things like full plane CIs, air contact investigation, with diagnostic testing because if there's asymptomatic transmission, you don't know. So the only way to do it is whether it's volunteers or to test everyone on a plane, as Vietnam and some of the other countries did, so that you can have an idea of what the true risk of transmission is. And then maybe working with a few state and local health departments with those persons to do follow-up testing diagnostic with those persons early on to kind of get an idea what the importation risk, symptomatic or not for those persons. The earlier in our response we can do that, I think the better we can add to what the travel risk is and what may need to be done. Over.
And I think it goes to strain surveillance too. One of the things that we've seen with all the variants of concern, not that we aren't cranking out our own variants domestically, but most of the ones that are really on the radar right now are being generated in large areas of viral circulation without benefits of vaccine. And we have recently had some pilots added to that. This gets back to Ed's question, is can we do a better job at looking for variant detection as part of that international movement risk assessment by building in strain surveillance into that component, whether it's through, looking at aggregate pooled sampling or some other approach. So I think that's part of a future pandemic readiness, is the molecular aspects as well for sequencing.
Thank you. Ruben Warren.
Yes, this was a very interesting presentation. We appreciate it. My question is about the qualifications and the skill sets of the people that you're trying to recruit and retain. I don't have a sense of the variance. Are they all the same skill levels, and are they different? In the past, CDC has not had a problem in recruiting, except for certain areas. And who are you reaching out to increase the pool of applicants?
So we have a wide variety of skill sets. So we have quarantine medical officers, which are either mostly medical doctors, but also some nurses. So we do recruit medical persons. We have veterinarians as well, and they're the ones who would be on the zoonosis team. And then we have communicators as well, for who would work in our communications kind of pipeline. We have a lot of them are what we call public health advisor skill sets. That would be our quarantine public health officers, and some of those transition to officers in charge or the regional officers in charge. And then we have people with preparedness training as well. I can't remember the exact category that they fall into. So Francisco and Deb, I left out, and those are at least 5 skill sets that we have. But again, the recruitment is a challenge, yes, but the major challenge is also the retention, because when people are burnt out, they need something that allows them some work-life balance. Francisco or Andy?
Yeah, I would. Oh, go ahead, Andy.
I was just going to add in, pharmacists have been part of our cohort as well, but specifically in kind of the operational side of the stations, our MPHs are building bridges with universities, and those graduate degree programs have been a good funnel to try to get new talent coming in, using the various mechanisms that we can to kind of get them in and get them the experience and give them the leg up to apply and get in. Francisco?
Yeah, I would add epidemiology and data management. And to some extent, we're trying to improve the way we come up with more innovative or more sophisticated ways of analyzing our data. Some of our gems in terms of personnel actually leave sometimes because we're operational heavy, and following the theme that Clive mentioned, being on call, for example, plays a burden. And so we're hampered in that regard, but we're trying to come up with ways to provide opportunities for those folks to feel engaged and contribute and advance the science of border health.
One quick comment. I spent 20 years at CDC, spent some time at NIH, and the loan forgiveness, particularly for recent graduates, MPH graduates, can be a very attractive opportunity. They're coming out with big debt, and I have an opportunity to be at CDC and then get loan forgiveness would be a tremendous advantage for them, and I think for the agency as well.
Let me add one question.
For a lot of the students that I talk to, so that's a very good point.
Let me add one question. There's a large number of folks coming out with undergraduate degrees in public health. And then, of course, you folks used to use folks with 2-year degrees. Are either one of those still pools in which you can recruit from? Yeah, so certainly the post PHAP, as Mark mentioned, early Q4, they are GS level 5, right? And this many of those people. So certainly at the introductory level, there would be some. Now, the decision, there are lots of decisions that folks at the quarantine stations and everyone needs to make. So we are careful not to have, an overabundance of, say, GS5s. But yes, certainly for people who are new and coming into the program, that's an acceptable entry. Andy, any corrections there?
Oh, so the PHAP program really gets them in at a GS 5 to 7 level. Master's candidates are coming in at a GS 9, and typically our QFO positions are a 9, 11, 12 track that allows people to kind of grow into the experience of the position and gain that seniority. To Clive's point, you know, we do have some limitations with relying on younger or lower GS level staff just based on some of the regulatory review and the other kind of critical level decisions that our quarantine officers need to make, including a new expedited do not board process, which requires a senior level quarantine person to make a determination whether or not someone's going to need to be added to the do not board while they're actually at the airport actively engaged in transit. So the seniority is a kind of a critical part of making sure that our stations are equipped to take on a lot of these challenges. If we're too bottom heavy, a lot of those decisions end up filtering up to higher levels, and that kind of goes to some of the other examples of burnout. Too many decisions are being made at a level with OICs having a broad jurisdiction and area of responsibility, and all this kind of collects at a top-heavy level for these decisions. So, over.
Okay. I'm going to take the hands up I've got now. So I've got Andy, Michelle, Marcy, and then Lonnie.
My point was already covered in Francisco's comment in the chat. I just wanted to add in to the question regarding wastewater surveillance, specifically on airplanes. There was 2 limitations that were pointed out by our SMEs at CDC for a pilot project that was proposed in the Los Angeles International Airport, and that's in the chat for everyone to review. Over.
Thank you. Michelle, are your hands still up? No. Marcy.
Sorry, it took a second to unmute. Well, first off, I mostly wanted to acknowledge the amazing breadth of activities that the quarantine station does. I think sometimes as we focus in on this particular issue of monitoring travelers, we forget everything else that the team mentioned, and I've had the privilege of working with them on almost all of those issues, from imported dogs to arranging botulism toxin, et cetera. So I just needed to, it was great to be reminded of everything else that I've worked with the quarantine station on over the years. I will also say I've noticed the staff burnout because I used to know everyone there by name, and they've turned over a lot in the past couple years, which is striking to me. I still know the number by heart for the JFK quarantine station since I started calling them before cell phones. But that was my comment. My question is, I think it was Clive's, one of Clive's slides that showed the number of cases, and maybe even I feel like there was also deaths on there that were thought to be related to transmission on airplanes. And I just wanted to qualify that. I know that in New York City, when we interview COVID cases, they do ask about recent travel. Their time frame is more when the case themselves were infectious to identify potential contacts, not identifying transmission when the plane. But I'm wondering if there's any data to look at transmission on planes from, like how effective that once you identify someone has traveled, the ability to actually use that data.
So that has been highly problematic, and hence why I said the name, to have surveillance with molecular, with DNA tested involved. So of course, one, a lot depends on the incubation period. So where did exposure occur? Was it before? Was it on the plane? Was it after they arrived? So that's often a major limitation. We work closely, of course, with the state and local health departments to try to narrow that gap and get that analysis. As you know, although we send the data to the states on EpiX and we request that they respond, it's not a requirement that they respond. So very often the response rate is really less than we would want it to be. And so there are some challenges with then making that analysis. Now, during COVID, I did do a reach out specifically to the quarantine station, to the state and local health departments for COVID. And we got what would seem to be a fair response rate. What I asked them to do was here's a list of persons we have, match that with your lab database, and then send that information back to us. However, just about the time we were going to analyze that data, the SMEs came out with a report that only 1 in 8 of the COVID cases are probably reported. So then that meant there was going to be another gap in our analysis. And after discussion with Marty, we decided it was best not to put information out, which would be misleading, because there's just so much. So there's asymptomatic transmission, and then there's underreporting even for the lab cases. So it's really very hard. Marty, anything you want to add to that?
No, except the really well done studies that are already in the literature. Marcy, you've probably seen some of them. They're mostly non-US based, and they involve, carefully looking at who only met and only over intersected in the travel experience. You can't really separate the airport from the plane so well. And then they've got, molecular studies, and then other countries that were quarantining after arrival found the asymptomatic cases that converted and could get their strains and match them to the passengers on board, but not to their travel mates. That's the kind of way to get at that. I think it's pretty hard. Industry paid for the Harvard group to do a bunch of, I would call them sort of in vitro, if you will, simulated model of transmission. And then a lot of that number, the denominator and the numerator, were exploited because we really didn't ascertain all the cases, and not everybody in the denominator was an exposure risk. So it's pretty tough to get at that in any meaningful standard epi way without a lot of work.
Okay, thank you. Lonnie.
Great, thanks. The conversation this morning has reaffirmed what we already knew. This is not about working longer and working harder. It's about working smarter. And so my question for you is, you're getting so overwhelmed and swarmed under. Where is the look at new tools? And Marty, you said promising technology. How are you thinking about that, and who's doing it for you? So there's two things that I see. I was interested at CDC standing up a new disease forecasting center based on data analysis and data analytics, I would assume. Are you coordinating with that group already to talk about needs? And is there an academic home or group that you're dealing with, or is it NIH or somebody else, to say, these are the problems we have, this is working smarter, these are the new tools that we need? Where is your R&D taking place that specifically helps with your problems?
You're spot on. So many years ago, we created a unit called IDEA. It's a subgroup for innovation, development, evaluation, and analytics. That's where our incubator place is. Ardith Grills heads that group up. It's been quite extensive. It has a lot of tentacles, both to the private sector as well as academic universities. And it was through that group, essentially, that was part of the larger process of recruitment in the data analytics group. So Dylan George, Mark Lipsitch, and so we've been involved with that group through IDEA for at least going back to sort of Ebola, if not just a little bit earlier, connected with them. But it's really great to see that crystallize as an entity within CDC. And we've been pushing and promoting that CDC have its own place for that type of work. In that space, we are looking at all sorts of innovative models and approaches. It's the place where we've invited some of the academic research that's going on aromatic detection. We had the monkeypox experience. One of the things I learned about monkeypox after our ban on prairie dog importations was that, the giant Gambian pouch rats, is that they are incredibly good sniffers. They sniff out landmines across much of the world, and with a little bit of training and some watermelon incentives, they're also pretty good at finding TB in culture before it ever grows and it's detected by normal roots. And so we have benefited from stimulating those relationships, but I would say they're moving slower than they need to move if we're going to keep up with an evolving pandemic threat picture the way we are. And but I do think you're right, Lonnie. It's relationship with the private sector, the academic space. So on digital technology, we've been working with a number of folks that are doing the Sarah Alert project, for example, as a way to streamline the efficiency, be smarter about contact tracing and push and pull notifications. We have a dedicated part of the division that is only focused on that work. And we have a number of grants with academics, whether it's GeoSentinel, which goes back 25 years, or the various types of activities and Sentinel networks on the border, as well as in travel clinics that Dr. Ryan is familiar with. So we have a number of these systems and have had some for longer than others, but it is all about working smarter. It's not just beefing up and doing more of the same thing. It will not get us where we need to go.
Okay. I think that's all the questions. Michelle, you had one that you put in the chat around testing.
Francisco and Marty and Clive, since you do have a great paper showing that it works pre and post testing, and Mina, I'm sure you follow the work of Mina, why aren't we testing on the plane and then giving a cheap, $10, $15 Binax for 5 to 7 days or whatever?
So I think on the plane is a little late. I think at the airport before.
Okay, so I
think on the plane is really problematic when they're at 30,000 feet. But we have been in multiple pilots that we've conducted, both with private entities and with state and local health departments, in doing, both two-step with Delta 3 days before, and then prior to boarding an international flight, these went on in individual corridors. We have a program going on now that's post-arrival that will collect specimens, pool them, look for testing, and then they'll do PCRs so that they can actually get strain surveillance out of that. That is very much an active part of our research agenda. I think it's going to be important to do that testing before keeps COVID out of the transportation corridor. Testing after helps you deal with the incubation period issues. We found a lot about how you can shorten quarantine from 14 to 7 with asymptomatic and 2 well-timed negative tests. So we've been really pushing those limits a lot. And it has been our work with modelers as well as field trials that really have led to the promise of much more rapid testing in that space.
So is money the issue? What's the issue?
You mean in terms of scaling it as a national policy? I think it's not necessarily limited to money. I think it's the broader policy process that these are really big deals. Right now, we have a lot of our focus on international arrival. One could say that over many periods during the pandemic, our domestic transmission was much higher than necessarily the imported threat, and yet getting acceptability for some of these ideas in domestic travel has faced some hurdles. So it's not all about, as we've said in the beginning, the pandemic control as a whole of society approach. It requires public health politics.
Your diamonds. Right?
Yeah, the diamond. I mean, it is about getting everybody on board with an approach that in the end, I think everybody can win from. But in the near term, there's a perception of tension and winners and losers. So it's not, I wouldn't say money is the major obstacle in public health to getting some of the science stuff across.
Well, thank you, Marty. So folks, just to give you a sense of what we're doing. So we're ending today promptly at 2 p.m. And so we're going to get ready to go into closed session now. So I'm going to give ourselves about 5 minutes. That will allow us to stop the recording, our federal guests to depart, and for also for any community members that are listening for us to detach from that broadcast as well. So if we could be back in basically 5 minutes, and then we're going to talk for about 15 minutes about where we go from here, and are there any other salient parts? I let the discussion go because we're getting a lot of the answers that I thought we would get through, in our private discussions, deliberative discussions anyway. And just recognize we're also going to see our CDC colleagues back, I think, on the 18th. So with that, let me thank Marty and your colleagues from CDC to leave. We can go ahead and stop the recording and we can stop the broadcast.
Thank you all.
Thank you.